Welcome to Mind Your Being. Big hello to regular listeners and also new listeners. Thank you for tuning in. Today's episode is a very personal one for me. We're going to talk about obsessive compulsive disorder, known as OCD. If you've been following the podcast recently, you would have heard me share that I have struggled with OCD for most of my life. It's something that I have carried a lot of shame about, and until recently, I'd only spoken about it with a handful of people. OCD doesn't discriminate. It affects people from all walks of life, and it's not something that happens by choice. So at 51, I realised the shame that I've carried is wasted energy, and I really want to talk openly on the podcast about different mental health conditions and different disorders that people struggle with to help us all have a better understanding, to help reduce the stigma that still exists, and to help people not to feel alone and to understand the evidence-based treatments that can help. Joining me today is Dr. David Cooper, a clinical psychologist and lecturer at the University of New South Wales. David works with people with OCD and other repeating life challenges. He's involved in research to improve OCD treatment, and he maintains an online directory where people can find clinicians who have expertise and experience in treating OCD. Dr. Cooper's private practice is located in Kiama on the south coast of New South Wales, Australia. This is a beautiful conversation and I really enjoyed talking to Dr. Cooper. If you're living with OCD or any mental health condition, or if you're supporting someone who is, I hope it helps you feel understood, to feel less alone, and more confident about finding the right support. Please enjoy this conversation. Welcome to Mind Your Being, David. Thank you for making the time today.
Yeah, thank you for having me. It's wonderful, the podcast that you're hosting here. This is fantastic. So I'm glad to be on it.
Thank you so much. I really appreciate it. Could you start by telling us a bit about yourself and how you came to focus on working with people with OCD?
Absolutely. Yeah. So I am a clinical psychologist, do a little bit of research on the side. The way I came across OCD was actually really early on in my training. And I had a thesis supervisor who basically said, hey, you should look at developing some expertise in OCD because it's such a rewarding sort of type of work, wonderful sort of people to work with. And really, there's so much misunderstanding out there. That they really need more people to be able to to bring their expertise to this and more clinicians who can do this. And my response to him was something along the lines of, look, that sounds really tedious. I'm not interested. Thanks very much. And I think it just represents the misunderstanding and the stereotypes that are already out there. And so that was, really early in my training. And he was gracious and sort of let that go. But I realized I needed to learn more, needed to understand a bit more. So I started listening to some podcasts, the stories of people with OCD, and I was just so struck by how diverse it was. I thought it was just hand washing and checking and this sort of stuff. Yeah. Realizing how diverse it was and how, so many people, they had these stories where they thought it was just some weird thing that was going on for them and they thought they were crazy and they had so much shame around it and often had really long treatment journeys until they found someone who knew what they were doing with OCD and so on. And it just really, it just hooked me. And I thought this is wonderful that they're running these podcasts and that they're getting the story out. And gosh, we really do need more psychologists who know how to treat OCD, who build up that additional expertise. And so early in my training, I basically just started saying, give me clients with OCD. Let's, where can I get a placement or an internship and work with people with OCD, and just went from there. And it's really been, the primary focus ever since. Ended up doing a PhD after my clinical training, looking at how we can improve treatment for it and so on. And so, I think it was just hearing those stories really hooked me.
Wow.
Yeah.
Isn't it the way, though, that sometimes a supervisor or someone else can like just make a single comment and then it leads you on this journey and here you are now?
Yeah, absolutely. And yeah, he was really, really modeled how to sort of graciously address, the stereotype or the stigma as well,
That's
but
beautiful.
yeah, and encourage that. So it was wonderful. And yeah, obviously had a big impact now.
Yeah.
Yeah,
How
on
many
my life.
years later is this since he sort of recommended that?
Gosh, it would be 10, maybe a decade ago,
Wow.
maybe even longer than that. I can't quite remember. I'm not really good on the maths there, but
Been a
a fair
while
while ago.
now. So, as you mentioned there, initially, your understanding was the
Hmm.
hand washing or the compulsive
Hmm.
checking, which is
Yeah.
the common stereotype, I guess, for
Yeah.
OCD. There are so many misconceptions. And could you
Yeah.
please explain to us, firstly, what is OCD?
Sure.
And then perhaps we could talk a bit more after that about what is not OCD and what conditions may or may not overlap with
Yeah.
OCD. So,
Really good questions. Absolutely. I think, firstly, OCD is less about the content. So whether or not someone's, worried about contamination or worried about whether or not they left the front door unlocked or something like that. It's actually a process that you go through. So normally the way I explain it to clients is we use the acronym OCD. So obsessive, which means all the sort of internal images, thoughts, urges, doubts that someone has that are unrelenting, unwanted, they keep repeating and they cause a lot of distress. And so that's the obsessions. And so yes, it might be something like, what if my hands are contaminated, or what if this thing is contaminated? But there's so many other variants of it. So that's obsessions. Compulsions, really the way people try and deal, most of the time it's the way people try and deal with the obsessions. And so trying to resolve something. And so it might be hand washing or checking, but again, we'll get onto if you want, we can get onto all these other sort of variants. And then OC, and then D is for disorder, or I normally like to say distress. Basically, it means that it's not just a quirk or a personality trait or anything like that. This is having a significant impact on people's life in some sort of way. Often we'd say, it takes more than an hour of brain power thinking about it or physically doing something. But it doesn't have to be an hour. It can also just have a huge impact on their emotions or their family or their work or something like that. Yeah. So that's how we would look at it from a diagnostic perspective. And again, it's a process rather than the content of the concern. The other question here was, I've forgotten your other question. I'm sorry.
it was what is not OCD, because I think one of the common misconceptions, people think if they like things in an orderly manner, or like you said, if they check things a lot or doubt themselves, I think it's the common vernacular is to say, I have OCD, but they may not. If they don't have the obsessions that then lead them to perform the compulsions to neutralise or lessen the anxiety of the obsession, that's not OCD, is it?
Potentially no. Yeah. And I
Well,
think
yeah,
it's so tricky sometimes. It is a really tricky disorder to sort of draw a line sometimes and say this is OCD and this is not. There are, as you say, there's a bunch of overlapping things. So we see this in just perfectionism in general. We also have people who have a preference for routine or a preference for things to be a certain way. We often see this in autism as well. On top of that, there's things like tics, complex tics, vocal motor tics, visual sort of, moving your eyes, or, there's a range of things there. There's skin picking and hair pulling. And so there's all these other, even generalized anxiety, you might have repeated worries. There's a whole bunch of things that sort of overlap in a way that are not necessarily OCD. And I think this is why it's so important. Two things. One is to see someone who knows what they're doing with OCD and can differentiate, because if you end up with a treatment for something else when you need it for OCD, it's not great, or vice versa. Right? If you're treating someone's stimming in someone who's autistic and they're stimming and you're treating it like OCD, you're actually just doing harm. And so it's really important to see someone who knows what they're doing there. And it's also important just to step out of the content of it. So just because someone's doing something repeatedly doesn't mean it's OCD, and actually to look at the function, why they're doing it.
Yeah.
So yeah, there is a lot of overlap.
Yep, thank you.
Yeah, with a few other things.
Okay, so as you alluded to as well, OCD can present very differently and there's a wide range of presentations. Could you perhaps go through some of the more common presentations and then maybe some of the less common ways that OCD shows up for people?
Yeah, absolutely. So of course, I think the most common, the stereotypical one, is contamination. And to be honest, it makes sense because also 70% or so of people with OCD do have some sort of contamination concerns, but they can really vary. So some people are worried about getting sick. Other people are worried about making other people sick. Some people are worried about becoming morally contaminated or emotionally contaminated as well. And so we're not really looking at, the stereotypical, whether or not I end up with an STI or something like that, that we would often see maybe 10, 20 years ago. It's really varied. So we've got contamination. Another sort of general theme is responsibility for harm. And so this is sort of people who go, what if I've left the oven on when I leave the house burns down? What if when I'm driving and I hit a bump? What if I actually hit a person or an animal or something? And so they have to turn around and go back and check and so on. And of course, it overlaps with contamination as well. Some people say, I feel so responsible, I don't want to get anyone else sick. And so they're sort of, all their compulsions are around cleaning, but it's because of their level of guilt or responsibility. Another big theme is unacceptable thoughts or sort of taboo thoughts. And so this is where people have a thought, either something sort of blasphemous if they're religious, or it could be, thought about hurting vulnerable population, whether it's kids or sort of older people or something like that. Often it's things like, what if I blurt out some sort of insult, or what if I have some sort of sexualized thought, that's inappropriate? And they'll have this they might even have an intrusive thought, but then they sort of worry about, oh my gosh, what does this say about who I am? Another one is, what if I push someone on the train off the platform, and all this sort of stuff. Yeah. And they have these bizarre thoughts, even though they're never going to do it. Another theme here is that not just right experiences, which is often, as you said before, like having things lined up or having things in order. There is this sense that what if I can't handle this feeling of things being out of place? In the research, those are sort of the four biggest sort of buckets or categories here, but really they overlap, as you can sort of hear already, they overlap a lot. There's a bunch of others though, which I can go into. I'll give you a few examples for, if that would be helpful.
I think so, because I think there is a lot of misunderstanding about what is OCD. And as you said, I mean, it is so varied and it can present in so many ways for different people. And so please.
Yeah, absolutely. Okay. There's a lot of existential concerns as well. So what if life has no meaning? What happens after death? What if I'm going to hell? There's other sorts of things, like when it comes to relationships, whether or not, do I really love this person? Do I really have the right feeling for them? Am I really attracted to them? Or are they attracted to me? Are we meant to be together? These sorts of things. There's a whole bunch of overlap with sort of health anxiety as well. What if this mild symptom is indication of something that's really sinister? And it can often, there is this big overlap, but it can often express itself as OCD as well. And yes, we also have other things like, what if we're living in a simulation, or all these sorts of, so it's incredibly, I think that the main point that I want to get here is, if you can imagine hypothetical possibility, OCD can hijack that. It's really, the theme is limited by your imagination, which is pretty diverse, right? And it's usually driven, it's so personally driven by usually what's important to you. It strikes at your values. And in some ways, there's a really strong theory out there at the moment, and they're still doing research in this, but it's sort of driven by the sort of person that you fear becoming, in a way.
Right. So antithetical to who you actually are.
Absolutely. And exactly opposite of who you are.
I guess increases the distress for people.
Yeah, exactly. So someone who's quite conscientious fears becoming a negligent person, in a way. And, it's the conscientious ones who also worry about, what if I've hit something, or what if I've said something that's upset someone and they review it over and over.
Yeah.
And so on. Yeah. So it's always that, it's the opposite of who you really are in a way.
So I know for me personally, a lot of the time, if I've been right in the thick of OCD, the obsessive thoughts, a lot of the time it'll be something like, if I don't do a thing, and that might be just walking around a pole the like clockwise way or something, or stepping on the crack in the footpath, something like that. If I don't do the thing, then something bad's going to happen to someone I love. And it will usually be a particular person. And that's so distressing. And I sometimes, like it even happened the other week, sometimes I can recognize, rationally, I'm like, that's not a rational thought. But still sometimes it becomes that distressing that just to quickly do the thing anyway.
Absolutely. Yeah.
And sometimes, yes, you can get into the spiral where it takes a long time to sort of come out of that. For me personally, most of the time now I can remove like spiraling down, but
Get out of that.
yeah, there have been times
absolutely.
where it's really exhausting, and you can recognize it's not rational, but when it's an emotional thing or so distressing for that thing to happen, and what if I were responsible if that did happen? If that makes sense.
Yes, absolutely. And I think, and this is one of the key parts, I love that you're sort of describing this, that yes, people sort of say, look, on the one hand, it doesn't sound rational, or I can tell that this is not rational. And on the other hand, it feels so compelling, so absorbing, so captivating. And I think it's translating really what's this imagined possibility, like hypothetically, the universe could be, this is often what I hear from people. They sort of can almost reason this story that hypothetically, if you can rationalize this or explain some way the universe is set up like this, as soon as you take that hypothetical possibility and treat it like it's real, my gosh, it feels real. The imagination is so powerful, and we know the imagination is linked with the emotion. If you imagine something, you feel it. If you imagine something angry that makes you angry, you feel angry. You imagine something funny, you start to laugh, or you're amused by it, and so on.
Yeah.
Same thing happens here with OCD. If you imagine this hypothetical possibility and it feels real, you're absolutely hooked emotionally. And so it makes sense to do the compulsions. It makes sense why people do them. Of course, the compulsions then are almost acting as if it's real. It's like role-playing this hypothetical situation. Now you're bringing it into reality
And
so
then
it
that
feels even more
reinforces the
real.
loop, doesn't it?
Exactly. Spot on.
Unfortunately.
Yeah.
But it's that responsibility piece. Even if you can recognize in a split second, well, that's not rational for me to walk on that crack. That's not going to affect anything. But it's just like, well, what if something did happen? I would never forgive myself.
Right.
So I'm just going to do the thing.
It's
all
that
in a
doubt of
split
that
second.
possibility. Happens so fast.
Before we get to looking at how a diagnosis happens and what treatments can help people, just briefly, what do we know today about how OCD comes about, or who is susceptible to suffering with OCD?
Very briefly, it's a soup of different factors. We can't sort of put our finger on exactly one and say, this is it. I think that's really important to sort of say, is it a mix of sort of nature and nurture, or sort of biological and psychological, or sort of, how you're wired, and also your experiences here. What I want to emphasize is that it's definitely no one's fault. It's not sort of parents' fault, or if there was a trauma, yes, that's not helpful, but also it doesn't automatically produce OCD. What we do know is that there is a heritable component. So often something genetically is going on. We often see it more when there's other neurodiversity, when someone's either autistic, or they might have some other tics or other things like that. And so we know there's something biologically going on, and there's certainly a lot of research that backs up the idea that this is a brain thing. And at the same time, we also know that there's some psychological factors as well. And so if you have a certain belief about yourself, or some earlier experiences that have sort of reinforced this sense of guilt, or this sense that maybe you're a bad person or something like that, then that can sort of contribute to it as well. But we'd say it is all just contributing factors rather than a single thing. And we don't know exactly why they all sort of lock together sometimes to produce OCD.
Thank you. And as we've talked about, and we'll get into, even though we don't know exactly, and it's a number of factors, there are treatments that can help that don't really depend on how it originates. Is that right?
Yeah, absolutely. And what's amazing is even with those treatments, that the brain imaging studies show that the structure changes in the brain through the treatment process, even though we're not actually doing any surgery or medication. Even when it's therapy related, we can actually see changes in the brain.
Wow.
Which is really cool. Yeah.
That is cool. That's awesome. Before we look at treatment options, because every case is so different, as we talked about, in your experience, what are some of the challenges people face in getting the right diagnosis?
Gosh, yes. So I did a bit of research in this actually a few years ago, reviewed the research literature, and then we did a small study here in Australia as well. Two biggest factors that we found. One was that people just didn't know who to see or where to go. Part of this is just not even knowing sometimes that it is OCD, not even recognizing that the symptoms that they're experiencing are something, we know what this is and we know what to do with it and so on, because it wasn't your stereotypical hand washing or something like that. Not knowing who to see, where to go. And often people also, as part of that, might even see a psychologist or their GP or something like that. But if it's not picked up as OCD, they're not getting the right treatment for it and so on. And so that was one. The other one is that essentially people felt ashamed about their problems and wanted to handle it on their own. And I think both of them come back to sort of this misunderstanding about what it really is and what it looks like and so on. And yeah, so those are probably the two biggest factors. And if we can sort of destigmatize and remove some of that self-stigma around what's going on and really just build some understanding and compassion, I think that would help to reduce the barriers.
For sure. I mentioned to you when we spoke before recording, one of the big reasons I asked you to come on today is to share awareness, because there are common misconceptions, but also to try and help normalize that. Everyone has things going on for them, and for some people it's OCD. And as you mentioned, a lot of it is to do with the brain, and it's no one's fault. But me personally, I've mentioned to you, I have carried a lot of shame, and I'm 51 now, and a big reason, again, for having you on is I don't want other people to, wait till they're 51 to start talking about it or share it with someone or get some help. It's just, every condition should be normalized. People are different.
Yeah, absolutely. And it's not something you choose, right? It's not something
definitely not. Who would choose it? It's exhausting.
Absolutely.
And that shame, like to feel shame about something about yourself that you don't actually have any control over. And people might think this is weird. It's not helpful to anyone at all. And I think awareness is great. And like you said, if people can have more compassion. And I wanted to ask here, what are some of the factors that parents may be able to look out? Because obviously children might find it hard to advocate for themselves or might not even understand what's going on for them. But it could be really time-consuming, exhausting, and as we said, shameful. So what are some things that maybe parents could look out for to seek help?
Yeah, happy to answer that. And also, I love what you're doing here with the podcast as well, removing that or getting the right education out there, that message out there as well, so that people sort of understand that. With parents, OCD is, somewhere between 1 in 50, 1 in 40. So it's not the most common sort of thing, but it's fairly prevalent. And it starts often, there's a couple of points where it kicks in: childhood, in that transition to adulthood, and then for parents or new parents, people who are becoming parents as well, usually that sort of perinatal sort of stage. Those three are all times where people are trying to figure out who they are and how they fit into the world. There's something significant about that. I think though, for parents, if they're spotting repeated behaviours that are causing issues or distress, that's probably their best bet. at sort of bringing something up and really just inquiring curiously about it. The other thing that parents can do is also just check in with their kids if they're noticing that they're sort of withdrawn or distant, or, often the stories that I've heard from people who were later diagnosed as adults, when you ask, how come, you had symptoms as a kid here, often they would say, look, I was worried, but no one ever sort of said, hey, if you have any weird thoughts, you're always welcome to share them or something like that. I think the important part here, though, is as a parent, and I'm a parent as well, is to not freak out about whether or not your kids are, or sort of do some special screening or anything like that. Really, our jobs is just to provide the right context and make it safe to bring up, and give them an opportunity. But really, that's where it ends. You don't have to push this or search for it or something like that. Yeah, I hope that helps.
Yeah, no, that is great. And I think the thing is, we can get really good at hiding it. So, again, if parents don't recognize it when their child is a child, I mean, sometimes it's really hard to notice.
It is. And do you know what? Like, parents are doing their best as well.
Yeah.
And we often sort of even have to say to myself, good enough parenting is enough, right? And there is a sort of sometimes an anxiety about trying to make sure your kids avoid all sorts of things. You do the best you can. You give them the opportunities to bring something up and make it safe to do so. And I think that's as far as you can go at that point. A lot of those people don't blame their folks either.
No. You recognise no one has control over it. There's no,
And some things are quite transient as well. Kids will go through a small period where they're sort of reluctant or resistant to something, and it's important to not jump onto it straight away. Ask the question. And of course,
normalise any answers.
Absolutely.
Thank you. Just briefly before we move to treatment options, in your experience, what impact can untreated OCD have on someone's mental health, their relationships, and their overall quality of life?
Yeah, great question. I think so. OCD without treatment follows a fluctuating course. So symptoms will sort of wax and wane or come and go a little bit. The impact, though, is pretty wide-ranging, but it will depend on the specific person and how it affects them. So some people can work and they're unaffected at work, but they're in their relationships, they're really affected. For other people, they can't even get to work. They can't work at all, and they're relying on other support and so on. So it is very diverse in terms of the way it impacts people, but it can be across all those domains, whether it's work, health, physical health, emotionally, the relationships and so on, leisure, just enjoying socially, all those sorts of things as well. The level of impact on quality of life is quite similar to some pretty serious health conditions. It can be quite similar to schizophrenia or something like that in terms of the impact.
Wow.
So it is important to recognise, I guess.
Yeah. Okay, so what are the most effective evidence-based treatments for OCD today?
Great question. So, of course, we have medication is one option. I'm a psychologist, so I'm not a doctor, can't prescribe, but we know that is one of the sort of first-line treatments, particularly for adults. Still also okay for kids, but, with the right prescribing and so on. Medication's an option. A lot of people also choose to go down the therapy route. And the reason being is because often if you stop the medication, the symptoms come back. But with the therapy, if you do the therapy, you often feel a whole lot more sort of equipped if things sort of spike again. You sort of know how to handle it in a way. Part of that, though, it's a very specific therapy. So the first line, all the treatment guidelines will always recommend a first-line treatment called exposure and response prevention. So it's part of this cognitive, probably I've heard you talk before on the podcast about cognitive behavioral therapy. It's part of that sort of overall umbrella, but it's a very specific approach that was designed for OCD, and it's not used for other things. So exposure and response prevention basically means we're going to get you to confront some sort of thing that triggers the OCD and triggers that fear. And we're going to ask you to resist the urge to do those compulsions. And in doing that, what you sort of experience or learn is that whatever you're afraid of here, that hypothetical possibility is not actually happening in reality. Right? And so let's learn to stop responding to it as if it is actually happening in reality in a way. And so, of course, if somebody who's afraid of some serious illness, we're not going to expose them to the serious illness. We're going to expose them to whatever, if they're afraid of getting that from touching something in public, then we're going to ask them, hey, can we try and touch something in public here? And we're going to try not to wash your hands until an appropriate time, like a meal or something like that. And in doing that, of course, there's going to be some distress. It's going to be pretty frightening to begin with. But also as you work through that and you stay with that, you sort of realize, oh, hang on a sec, this thing that I was afraid of isn't happening and we're okay. And so the distress comes down. And the way we do it is, quite a graded sort of approach. Usually we start with something quite easy and sort of build up as their confidence builds as well and as their willingness grows. So that's the first line treatment, quite effective as well and really empowering for people.
And as you say, with the graded approach, and each time sort of would reinforce to the person, well, I've had a couple of times now and the thing didn't happen. I didn't do the compulsion and the thing didn't become reality. So I guess it, helps that way.
Yeah, that repeated learning, absolutely is important as part of the process for sure.
Apart from exposure and response prevention therapy, are there any other therapies or approaches that you may use in practice?
Yeah, absolutely. So exposure and response prevention will work for sort of 60, 70% of people, but there is a bunch of people for whom it doesn't work. Either they find it too hard, even the early sort of stuff, or it just doesn't get the outcome. So the other, again, under that umbrella of it, cognitive behavioral therapy, there's another approach that's sort of picking up a lot of traction at the moment called inference-based CBT. And it's a little bit more cognitive, involves a lot more sort of talk-related stuff, but it's specifically designed for OCD. It's the only other sort of cognitive behavioral therapy for that. There's a few randomized control trials that have come out recently that sort of say they're getting the same sort of outcomes as exposure and response prevention, but obviously different people will respond to different things, right? So it is helpful to have that sort of second thing as a backup here in the toolkit as well for people who, for whatever reason, the exposure and response prevention doesn't work out. So there's that. There's also some other sort of emerging things. My personal sort of favorite here is imagery rescripting, which is something, big focus of my PhD, but also there was a paper that just came out last week that sort of talks about imagery rescripting for OCD. And they've just done, a colleague in WA, Dr. Gail Maloney, has sort of just done 10 years of iterative research that have backed up this idea. And so it really is still in that early stage, but incredibly powerful, where we sort of tackle, essentially what we do is tackle the meaning behind some of these obsessions. And so what if, I said before, what if I'm a negligent person, or what if I'm guilty of something? And what they would do there is go back, really get in the time machine in the imagination, go back to a memory that really supports that idea that they're a negligent person, and re-script it, re-evaluate it, come up with a different ending. And of course, we don't have a delete button on the brain. We can't, we know what reality was, but often in that process, somehow people seem to re-evaluate, oh, hang on a sec, that situation wasn't me negligent. I was a kid. I was doing my best, I was getting blamed for whatever, and it changes their perspective of, who they are, or that meaning around this. And somehow it seems to affect later on when we get back to the OCD, we sort of fast forward to now, changes their perspective on whether or not they really need to do something because, hey, maybe I'm not actually a negligent person. Or
so attacking it from a different angle.
Yeah. Sort of going for that core belief, the background factors, that sort of thing as well. So that in itself is really, it's not a common approach, but it's, I suppose I'm sharing it to say there's more stuff coming. We're working on, there's some exciting things in the research here. But already great. just with ERP and inference-based CBT, they're great approaches to begin with.
But that's good to hear people like yourself are working on other approaches because, it's the same with everything. Not every therapy or modality is going to get the results for every person.
Yeah.
So if we've got more tools in the toolkit, it's great for more people.
Yeah, absolutely.
That's great. For people who feel just so stuck or resistant to treatment, what strategies can help them engage with therapy more effectively?
Gee, that's a really good question. And I think so many people feel like they've failed therapy or they've failed a treatment. And I think the first thing here is just to establish that they haven't. The treatment has failed them. The treatment isn't suitable for where they're at or hasn't been applied in a way that's right for where they're at. How can they engage after such a tough sort of journey up until that point? I think part of this is sort of understanding there is still hope for them.
Yeah.
I hope with either different treatment options. I didn't mention there's also schema therapy. There's a few other sort of things in the background here. Once you've exhausted other stuff that we say, all right, the research sort of tells us that when this isn't working, let's look at that. I think it's important to know that there are plenty of options here. Sometimes things, need to be at the right time as well. So someone's tried something 10 years ago, but also they had other stuff going on in life and so on. I think it's important to sort of recognize, I suppose what we're saying here is that don't give up hope.
Yeah.
That's probably the most important part. And working with a really good therapist who can hold that hope for them and also work with them to find their reasons as well. I think a lot of people, if someone simply just doesn't want to change, right, and is happy with where they're at, fine. Great.
Yeah. No
Question,
point
is
doing
this really a
treatment.
disorder, right? Is this, if it's not really affecting them and so on. But often it's people come in with that ambivalence, that sort of being torn in two directions. I want to get better, and I also really don't want to let go of this safety thing. That's usually more what we're sort of looking at here. And then it's a matter of working on what's important. How can we address some of those concerns, working with their motivation and their reasons for change, essentially.
Yeah.
Yeah.
Yeah, that's with any condition.
Absolutely.
When people want to change, there's always some resistance. And so again, I know everyone is an individual and it may look differently for everyone, but in general, what does recovery from OCD look like? Is it about eliminating the symptoms completely, or is it more about learning to manage them?
I love this question because I think this comes up quite regularly in therapy as well. It's funny, all the randomized controlled trials typically look at symptom reduction. And often this is how, and we measure things like symptom reduction often. But frankly, what does recovery look like? It's got to come down to the individual's goals. And it's got to come down to what does it look like for that person? What do they want to get out of this? And so often, yes, there is some symptom reduction, but also there's a whole bunch of other parts of their life. It might not be as simple as symptom reduction. It might be, I would love to get to work and to not have to return 4 times to check my drive, right? Or I'd love to be able to leave the house within 5 minutes instead of 45 minutes. So, I'd love to go into a relationship without sort of mucking it up within the first 8 weeks through excessive reassurance seeking or something like that. So there's some really sort of clear goals for people when it comes down to the individual. But yes, symptom reduction is part of that process. I think it's important to not fully lose sight of that. Most of the trials will often say, we get the symptoms down to a certain level where they no longer meet criteria for OCD. So essentially, there might be a couple of things going on in the background, but it's not having a big impact on their life. And that at that point, everyone with the trials will sort of pat themselves on the back here. Question is this a holistic recovery for the individual? It is going to be quite diverse and quite individually driven. Probably there was some research recently, a few years ago, that suggested that for the people who do get better from exposure and response prevention, about 80% of them will still have something going on, some thoughts or some doubts or something like that, but they know what to do with them. And that's the important part. They go, this isn't affecting me anymore. I'm okay.
That's great.
This comes up. I know this is OCD. I don't need to respond. End of story, And so only about 20% will say they're completely symptom-free, which is wonderful. But I think in treatment, we often clients often sort of want to get to the point of zero symptoms, which can be a problem in itself because then they're sort of worried about having OCD in the first place. So I would say it's a tricky balance between the individual stuff, but also we're really trying to get people to a point where they say, this isn't affecting my life anymore. Because frankly, we all have stuff that we worry about or that gets us down or that affects us in different ways. And we're not trying to get people to zero pain in a way or zero emotional pain, as much as we love that, because that in itself becomes problematic if that's our goal.
And I think the thing is too, that awareness of thoughts are not reality. And when you come to understand we don't control what thoughts come in, we can control our reaction, which is what the tools in the therapy can help you. How do you react to those thoughts? But is it common for people once they've gone through even if it's the ERP treatment, that just being able to, I know this is an OCD thought, and not react to it like they would have before, does that sort of tend to lessen the prevalence of those kind of thoughts coming in?
Absolutely, yes. And that's a wonderful part about it, is that in disengaging from that, treatment-wise, however they get there, in disengaging from that, the frequency of the thoughts does reduce and the distress does reduce. And so people often, once they stop responding to them, they come up less often. They're less concerned by it, and it hooks them less.
That's great. What advice would you give to someone who thinks they might have OCD but they haven't sought treatment yet?
Good question. If they think they might have OCD, most of the people that I talk to, the way they sort of end up coming in is, first thing is they've seen something. These days, they've seen something on TikTok or they've seen something on Instagram or something like that, and they've started searching their symptoms, and they've sort of come across something on Reddit, and they've gone, oh, hang on a sec, and someone has said this looks like OCD, and they've done a bit of searching. So if they haven't done the other one in the last year or so is people who've put their stuff into ChatGPT, which I'm not suggesting that people do because of privacy and all the rest of it, but I understand it happens quite often. And ChatGPT turns around and says, hey, this sounds like OCD. And then so if someone hasn't sort of done a little bit of poking around or reviewing or any reading on it, my first sort of suggestion here, jump on and just look at how diverse it is. Sort of Google some of these symptoms and see how it could fit maybe. The next step would be going to your GP, going to the doctor and having a chat with them about it. And certainly come sort of prepared to say, hey, look, I wonder if I'm having these experiences, these thoughts, or these sort of repeated actions or repeated thoughts, which I haven't mentioned. Often compulsions can be mental mental problem solving, or praying in your head, or repeating reviewing a memory, all these sorts of things. So they can go into the doctor and essentially say, this is what I'm looking at, and read here some stuff overlaps with OCD. What do you think? And hopefully often the doctor will suggest, either might just diagnose them right there, or might suggest, you know what, let's chalk this up to some sort of anxiety, and let's send you off to a psychologist or a psychiatrist or someone to start process of figuring out exactly what this is and what the treatment looks like.
And with that, as you mentioned before, it's important to get someone who understands and has experience in working with people with OCD. For doctors, but also for individuals, where can they go to make sure they're finding clinicians who are trained in these therapies that help OCD?
Yes, I love this question because, a few years ago, I just had spoken to so many people who had done this really rough journey trying to find someone, who was experienced in this. We got together with some others, and we ended up setting up this directory. So if you go to ocd.org.au/directory, there is a directory there now of psychologists, psychiatrists, and a few other clinicians there who have special interests and expertise in treating OCD. And they're all in Australia. So, availability for Medicare rebates and all that sort of stuff is there. That directory is probably the place that I would start, where you can sort of search by postcode and so on. But of course, there are other people out there who are, we're still adding to that directory. So there's other people out there who might be great at this, might be okay, but aren't in the directory yet. So the next question there, if you haven't found someone, would be to essentially ask them, what's your experience working with OCD? If they don't do exposure and response prevention, that's a big red flag.
Yeah.
I'd be saying, well, hang on a second. But yeah, it's completely okay to ask and to question, to work out fit, to say, hey,
Yeah.
do you do this? Do you have the experience in this? Are you trained in this? Or can you recommend someone? Yeah.
Yeah, definitely. That's a great resource, and we'll link to that in the show notes as well. You mentioned that that's in Australia. Are you aware of, because we have listeners all around the world, are you aware of any plans to expand the scope or whether any other countries have something similar?
Great question. Yes, for people outside of Australia, I'd probably start with the International OCD Foundation. So IOCDF, International OCD Foundation.org, iocdf.org. They have a directory as well that is, of course, international. It doesn't have as many Australian clinicians on it, which is why we created sort of our own. But yes, certainly I would start there for other people.
Thank you. I'll link to them in the show notes as well. That's great. So, do you have any suggestions for how friends, family, or even workplaces can best support someone living with OCD?
Right. Yes. So I think it does depend on how much the friends and family are being sort of co-opted or employed by the OCD. So often what
True.
happens is that parents or partners, because they care so much about the person, a child or a partner living with OCD, a loved one living with OCD, they will often try and help to make life easier through things like avoiding something or doing things for the person with OCD, essentially doing the compulsions or the avoidance on their behalf, or they'll be providing reassurance and so on. And so often if one of the ways to support them is to be able to work out and negotiate, often with some support with a clinician, but essentially negotiate, how am I going to reduce my role in supporting the OCD and work out how I can support the individual instead. And so I often have clients, with their families, with their partners or parents or someone in the session, and we talk through how you can essentially remove that, what we call accommodation in a way, but also support the person. So, often the conversations are something like, I care about you so much. I can hear this as OCD. I can hear this as tough, but because I'm on your side, it's you and me against this OCD. I'm not going to respond to that. Yeah. And so, come on, you can do this. We can get through this. Let's go do something else. Or, essentially, I'm not going to avoid that because this matters to you, because I'm helping you here. And so we would have those conversations. This is one of the sort of key ways, often that accommodation or that way other people are supporting the OCD and maintaining it. That would be part of it, but it needs to be a collaborative thing most of the time. If you're a parent or a partner or a friend or something like that, you can ask, I just open the question, are there things, or it feels like there are things that I'm doing to facilitate the OCD in a way, or the avoidance or compulsions? Is there a way that I can sort of reduce that to support you and still show you that I'm on your side and I'm on your team? That'd be one key area. Of course, the other stuff is around just reducing the shame, reducing the stigma, saying, hey, I get it. The imagination's weird, right? Like we all have weird imaginations. Yours is on fire at the moment. And really just providing that compassion, letting them know that you still see them as okay as a person, that you're not seeing them as something weird or anything like that. And then in terms of workplaces, of course, if there are things that they can do and if it feels safe and it's appropriate to discuss, that's great. But it would sort of almost apply just like any other sort of mental health thing as well, if possible, to make a little bit of space for them to process and still do their job, any sort of adjustments. But the mindful thing here, or the thing they need to be mindful about, and this is really on the employee, the person with the OCD, is to say, what's going to help me do my job? What's going to help me reduce the distress here and still just be able to live normally without enhancing or encouraging the OCD? So there's a bit of a conversation, a bit of thought and nuance that needs to go into that. Does that sort of make sense?
Yes, yeah, thank you. And they were all good points, but the one that struck me the most while you were talking was the label or the title of the disorder, OCD. That's for diagnosis. We are more than just our diagnosis, or we are more than just our condition or our symptoms. And as you were encouraging people to be compassionate and see people for the people they are.
Absolutely.
Because as we said before, everyone has things. If you don't have OCD, you may have something else.
Yeah, absolutely. And often it's a reflection of who they're afraid of becoming. It's the opposite of who they are in a way. It often represents some wonderful values for people. And often the values are around the people that you love, right? And having them close and having them safe and so on. So there's always something wonderful in all the mess as well. And treatment doesn't remove those values. I think that's really important to say. It doesn't change who you are, doesn't change what's important to you at a fundamental level.
I think sometimes, whether people are aware of the thought or not, I think sometimes people think, well, if I do treatment, it's going to change me as a person. And it, as you said, it's not going to affect the underlying beautiful values that you have, but it is going to help you with symptom reduction and help you to live a better quality of life.
Yeah, and often more authentic as well, right? More aligned with your values, because the bizarre thing is that often all the compulsions and all the avoidance and everything just backfires, right? And on people, and they end up more distant from their family. Treatment helps you live more authentically aligned with your values.
I love that. Before we wrap up, what gives you hope about working with people with OCD?
Oh, great question. Yeah, I feel like the correct answer as a scientist clinician here is to say the research outcomes are really good. I'll be honest though, it's working with the clients, just the amount of courage that they show. You can see when they first come in, just so hooked and caught up in these loops, and just seeing how much courage and determination they show as they sort of get through this. I think what really gives me hope is just over and over seeing the good stories. And sometimes they're a bit messy. Like I don't want to sugarcoat it and say they're done in 10 sessions or something like that. Sometimes it takes a fair while and a few different things, but it is really, I think, just seeing how people claim their lives back from the OCD. They get back to that quality of life or that functioning. They finally hit goals that they've been wanting to hit for a decade or whatever it is. So that's really what keeps me going with it. I love it. And even those in the session moments where they, at the start of the session, they go, oh my gosh, I don't, how am I going to do this exposure exercise? Let's give it a go, but I'm pretty afraid. And then, mid or late in the session, like, I can't believe I was afraid of that. That was, it's
that
just to
must be
see,
wonderful.
It's a wonderful experience with them to see them learning so fast or going through this sort of, even when it's not so fast, even when it takes a while, seeing them make changes.
Yeah.
Yeah. Often they've already shown so much courage in managing life up until now, right, without the treatment support. And so it's wonderful when they do get the treatment support, just for them to pivot that courage and, all that effort into getting better.
Oh, it's wonderful that there's people like you who've taken an interest and are helping people.
I'm grateful for all the clients that it's a privilege to work with them, and grateful to, that supervisor who put me onto this and set me on that path as well. So it's such a joy.
So we've covered a lot of helpful information today. Is there anything else that you'd like to mention or bring to the attention of our listeners?
Yeah, I mean, we've probably already covered it, but just the highlights here are that, if we're talking OCD, people are so isolated. And so it's important to sort of acknowledge that you're not alone. You're not on your own with this. You're not crazy or bad or something like that. And even though the symptoms seem overwhelming or a little bit bizarre, we can when we do a sort of map this out, do an analysis of this, we can always make sense of it, and we can deal with it. There's some good treatments out there, and so there is some hope. People deserve relief, and deserve to recover. So yes, put your hand up, head to the GP, jump on the ocd.org.au and look at the directory, find a clinician who's passionate about this, and get yourself some help if you can.
That's beautiful advice. And there are things that can be done and people to help us not to suffer so much. So bugger stigma, I say, just get the help you need. Would you mind sharing with us 3 practices that you have or 3 things that you do or use to mind your own being?
Absolutely. And so important. I think the first one here is is just relationships, and making sure that I'm, whether it's with family and with friends, sort of socializing as well, but essentially that quality time that's really important to me. And so getting some quality time with family and friends be number one. Number two here is time outdoors for me. And I think everyone's different here, but yeah, absolutely time outdoors, whether it's, so lucky to live on the coast and near the beach and so on, but yeah, anything outdoors. And then third, probably related, is looking after my exercise and sleep, and staying on top of that. And often personally, I'm not very good with consistency. So having to sort of vary things up and make things work for each day is important. But those are probably the three biggest sort of pillars for me to mind my being.
They're great. The time outdoors and the social time, it's so therapeutic, isn't it?
Yeah, absolutely. And I should add colleagues as well, in the work that I do. But, often it's really helpful to have those deeper conversations to find people that you can have those deeper conversations with as well. Yeah, and to be vulnerable with.
Yeah. Thank you.
You're so welcome.
I will link to the resources that we mention in the show notes so people listening can find those resources. Wonderful. So important, that directory of clinicians, because it's time, it's money, it's being vulnerable to go and get therapy in the first place. So you really, if you're suffering with OCD, you want to be working with therapists and clinicians who are experienced and have the treatments that actually work. David, I can't thank you enough for agreeing to come on today.
Oh, it's wonderful. It's such a joy to chat with you.
Thank you. For the listeners, this podcast is only possible because beautiful people like yourself have agreed to come on at your own expense of your own time, and because you want to help people, which is clear in the messages that you've delivered today.
Oh, wonderful. And I'm so grateful for you running this and for the people out there who are able to hear this and sort of get a new perspective on this and sort of know that they're not alone, or that they can support others. Yeah, I'm so grateful that you have this platform.
Thank you.
Thank you for running it.
You hit the nail on the head. For people not to feel alone and to have a better understanding, I think we've covered that today. So thank you again so much.
Thank you. All right. Cheers.
Thanks so much for listening to this episode of the Mind Your Being podcast. If you enjoyed it or found it helpful, please follow the show wherever you get your podcasts and share it with a friend who might enjoy it too. If you have a moment, please leave a quick review. It really helps others discover the podcast. Thanks again for being here. Take care, and until next time, mind your being.